Hello, everyone. My name is Grace Peng from the Interagency Modeling and Analysis Group, and welcome to the pre-meeting webinar series for the Conference on Integrating Machine Learning with Multiscale Modeling. The webinar today will be presented by Lieutenant Commander Slayton from the Centers for Disease Control and Prevention. She is the lead of the Mathematical Modeling Unit and also the Scientific Director of the Modeling Infectious Diseases and Healthcare Network. Dr. Slayton joined the CDC in 2011 as an Epidemic Intelligence Service Officer in the Division of Foodborne, Waterborne, and Environmental Diseases. Her group's work focuses on developing mathematical models to better understand the transmission and prevention of multi-drug resistant organism and healthcare-associated infections. Please welcome Rachel Slayton.
Thank you, Grace, and thank you all for listening in today. I'm excited to talk about the outline that a number of IMAG members have put together to think about the concept of human safety. Today's talk will focus on describing the levels over which we think that machine learning and multiscale modeling can help inform human safety. The idea of putting this framework together is so that folks have a better appreciation for the multiple levels at which human safety is really relevant and applicable for multiscale modeling. It encompasses multiple spatial and temporal scales in various environments, including those which are occupational, operational, recreational, and medical and surgical as well. We'll go through each level of this human safety framework to provide some examples of the types of problems that one might address when thinking about use of machine learning and multiscale modeling. The first level in the framework that the group put together is the individual or the patient level. This is the scale at which I think we begin to consider human biology, the physiology, what is actually happening within the patient. As you can see depicted in the picture on the left, that the patient is in a bed in a hospital, and that's oftentimes where the individual will be identified, and we'll have some ascertainment of what risk factors might be about what the progression of their illness might ultimately be. The individual patient, operator, or user level is that basic building block of this framework, and it's the level at which many data are collected, whether that be through electronic health records that could be utilized for advanced computational techniques in the future, whether there are data on human history, and also what the expertise and experiences are of that individual in that visit and in previous visits as well. The next level of the framework that we put together for considering levels of human safety is at the provider level. This is oftentimes the level that we think of for intervening because providers are actors in the healthcare setting. Providers make decisions about what procedures and processes to utilize when they are conducting patient care activities. They may choose to use checklists or other ways to operationalize more consistent practices across patients. Providers make decisions about what tests are ordered, about what procedures are conducted, about what processes the patient undergoes while in a healthcare setting. And in doing so, make choices about the kinds of data that may be generated that we can use in the future for mathematical modeling and that machine learning algorithms will be based upon. These providers also, as humans, have behavioral aspects that are interesting and need to be considered when thinking about ordering various tests and adherence to interventions that are considered to improve human safety outcomes. The next level of the framework we constructed comes to tools and smart instrumentation. We're moving away from devices that do not record data systematically, moving more towards automated collection of data in healthcare settings. With the increasing use of wearable devices and of smart technologies, like the smart thermometer that's depicted on the slide, there are more and more robust data that we will need to consider using for improving human safety. An interesting example that took a first stab at this is also shown on the slide, where thermometers were utilized by a group. They took data that was generated by individuals who were using thermometers in their home, had some information on who in the family's temperature was being taken, and used that data to help think about predicting influenza-like illness. The increasing penetration in the market of these smart tools and instruments really increases the data that are available and opens up quite a large number of technological considerations for safety that can be leveraged moving forward. The next level of the framework we constructed was at the team level. There are oftentimes team dynamics in the way that healthcare providers are trained, in the way that they communicate with one another, in the way that they interact with the patient to provide medical care and treatment. At the team level is also where observational studies are often conducted. And so it's an important consideration when thinking about the level at which data are collected. They are grouped together in certain ways, and this can be leveraged for human safety improvement efforts as well. Additionally, a member of the team that is important to consider are medical advocates who are helping the patient articulate what their needs are and to help bring attention to important issues that may be underappreciated in human safety at a larger scale. The next level that we considered was the system level. We begin by thinking about individuals and providers at their own level, how they start to come together as teams, oftentimes within facilities. But we need to consider moving up to the next level on as well, the systems level, where we have networks of healthcare facilities, such as those depicted on the left, where patients are moving among different healthcare facilities that may operate on an individual level, but the interplay among them is quite important for how human safety looks at a larger spatial and temporal scale. The patterns at which healthcare facilities interact with one another may also be much further reaching than we would consider without looking at data, such as the slide, the figure on the right of the slide, which depicts the state of California and actual patient transfers among healthcare facilities. By using machine learning and multiscale modeling, we can begin to appreciate these systems-level phenomenon and how they impact human safety as a whole. The system level does not only include hospitals and healthcare settings, such as nursing homes, but we can also think of the systems level with regards to research facilities and centers of excellence for different kinds of healthcare issues, how there are methods at which we aggregate folks together. And there are systems level influences for how we have human safety issues such as accidents, how we can really leverage this broader level of entities that work together to improve human safety, and need to be cognizant of this when using data to build models. The next level we described was the population scale. At this level, we begin to consider the geographic locations over which individuals are interacting with one another. So systems may or may not span meaningful geographic that are relevant at the population scale. We also have population level data about quite a large number of human safety and human health outcomes. And we can conduct analytics of how records vary over time and space, how there are interactions and externalities that impact human safety within healthcare settings, but also outside of them. And as an epidemiologist at the Centers for Disease Control, it's at the population scale that public health really comes to interface with actors, oftentimes of state and local health departments, about how we can improve human health and safety. Next, we come to considerations about the disease level or the injury level. Depicted on this slide are a number of multi-drug resistant bacteria, so that we remember that human safety needs to consider organism-dependent phenomena. We have different durations of colonization, of infection, of infectiousness that at the population level really influence how infections across the population spread. But this disease and injury level is also incredibly important for how illnesses progress at an individual patient level. And these are also important for how injuries, such as traffic accidents, depicted in the photograph of an individual buckling up as they get in their car, that human safety spans this additional level. Finally, the last consideration in the framework that we constructed was the data information and sharing. So the picture on the left depicts actual data collection at CDC in the 1980s on one of the earlier computers where data were entered by hand, and there were limited ways that we could actually leverage these data to understand larger scale phenomenon and to use these data to guide our approaches for prevention. As we have moved forward in time, the data quality have improved substantially, which open up many opportunities for additional data analyses, such as machine learning and multiscale modeling. These allow us to compute performance measures to understand how we are progressing through time, if things are getting better or worse, and to learn from the data about how to target improvements to human safety in the future. We can link these with existing medical data that come from the individual level, that come from providers, that come from the smart tools and from the teams, and use these data at large to improve the way that we protect safety. Some examples of how we have started to use machine learning at CDC are shown here, and I'll give you a brief overview of a few of these really interesting analyses that I think highlight different levels of the human safety framework that we have put together. So at CDC, data has been used combining disparate influenza models to improve prediction about where we are in the influenza season so that providers and patients have better information about what to expect is coming, and these data can also be used to motivate increased uptake of vaccination, for example. That's through ensemble learning. Other folks at CDC have used machine learning to identify sidewalks from Google Street View through image recognition to try to understand how the broader systems level and the population scale are influencing human safety. Additionally, Quite a number of groups at CDC have been predicting who meets a case definition from free text, from data collected through quite a number of different traditional and non-traditional sources of classification. And these are just a few high-level examples of how machine learning is beginning to impact human safety. We hope that by presenting this overview and then giving 2 examples through these other talks, you'll see how the digital twin concept can be applied to multiple levels of human safety problems, and that there are ripe opportunities for improving human health through variable uses of machine learning and multiscale modeling. Thank you for your time, and I hope you'll also have an opportunity to listen to some of the other pre-meeting webinars that complement this one. Thank you, Grace.